is discussing the diabetes landscape about type 1, type 2, and gestational diabetes. If you are new to DPAC, first of all, Happy New Year. Welcome to DPAC. Our mission is to ensure quality of and access to care, medications, and devices for patients living with diabetes, and to educate, inspire, and empower patient advocates, as well as lawmakers toward meaningful action on diabetes. So we educate people in the diabetes community on how to be advocates for themselves and through DPAC. And we also provide more of an educational and in-person, first-person experience piece for legislators to talk to people with diabetes. Today, we have two featured speakers. Donna Ryan is on the DLC Board of Directors. She's a registered nurse and registered dietitian with over 30 years of experience specializing in diabetes care and education. Currently working as a consultant for diabetes-related devices. She's also a national speaker and author. And her personal link to diabetes started early in life with family and friends with type 1 and type 2 diabetes. Dr. Stephen Edelman is a professor of medicine and in the Division of Endocrinology, Diabetes, and Metabolism at the University of California, San Diego, and the Veterans Affairs Healthcare System of San Diego. Dr. Edelman, who has type 1 diabetes himself, has written more than 200 articles, 5 books, and has won numerous awards for teaching and humanitarianism. He has been chosen by the medical students of UCSD as the Teacher of the Year numerous times. And among his many honors, Dr. Edelman has received the Diabetes Educator of the Year award by the American Diabetes Association, the Distinction in Endocrinology award by the American Association of Clinical Endocrinologists, and named top 1% of endocrinologists by US News and World Report.
You better start. No, that was a long intro, but thank you.
Yes. Yeah, I mean, I had to give you all the credit that you deserved. So thank you. We have two really distinguished speakers with us today, and we're really grateful and lucky to have them. Let me stop sharing and put the spotlight back on you two. Okay, so we'll go ahead and get started with our questions for today. So both of you are experts in the medical field and have spent your careers in diabetes care. Could you each tell me a little bit more about how you developed interest in this focus and which aspects of diabetes you have drilled into?
Donna, please go first. It's nice to see you again, Donna. Donna and I have done many programs together through the years, so it's good to see you and speak with you again.
Always a pleasure to work with you, and I'm happy to be here. Hi, everyone. Diabetes has been my passion for many years. It started out, I went to college and I went into nutrition and nursing. And my first job was in East LA, East Los Angeles, in downtown. And I started working in the barrios and working around people that really didn't have access or education to anything to help take care of their diabetes, and they'd come to the clinic. And my passion grew when I saw that there was such a need and such a gap. And from there, I started working with nutrition and medications, but I really quickly went into devices. Back in the 90s, we started with insulin pumps. So the more I learned, the more I could share with the people with diabetes, the more passionate I became. So it's been a lifelong journey working with that. And then on a personal note, my baby brother called me one day 10 years ago and told me he had diabetes. He was back here in Florida, and they'd given him some pills. And he didn't know much about it, and he mentioned some things that made me really worried. So multiple phone calls. We tried to get him back into the clinic. It didn't go well. He passed away 2 weeks later. And here I'm working in Los Angeles, trying really hard to help people have access. He didn't have insurance. He didn't have access. So it hit home, and then I doubled down. So I've been working in advocacy and focusing in advocacy and access and equity for diabetes and people with diabetes and everything that they need to stay healthy.
Wow, I never knew that, Donna. I knew you had a brother with type 1. I didn't know he passed away in 2 weeks. Oh my gosh, I'm sorry to hear that. You can, obviously it still affects you, and it should. my story is, it starts when I was born. I developed type 1 when I was 15. And as I grew up, I wanted to become a diabetes specialist. And so went to medical school. I went to the Joslin Clinic. I came to UCSD to do research in diabetes. And then in 1993, the very famous diabetes control and complications trial was published. And it was for many of the younger folks on the line, it was like a 10-year study to prove once and for all that if healthcare professionals take the time and effort to get their patients' glucose under control, A1C, then they should avoid complications. And if they have any complications, delay the progression. So that really was a game changer. Now, I always believed tight control or adequate control was important anyway, but many caregivers in this country, they needed the proof. I always say caregivers, I mean healthcare professionals. So in 1993, I was expecting many healthcare professionals to change their practice habits because a lot of doctors, they didn't put any effort in. Someone's A1C was 8, 9, 10%. That's fine. But then the study came out and things didn't change at the community level. So an idea went off in my head, 1995, 2 years after the DCCT. I was very, very frustrated with professional education. I felt like once they graduated their residency, very hard to change their practice habits. So I said, I'm going to put on a conference for people living with diabetes, not healthcare professionals. And that was a very unusual thing back then. There's always medical conferences for doctors, nurse practitioners, the prescribers, PAs, and that was the start of taking control of your diabetes in 1995, which I founded back then. That was over 25 years ago. And so over the next 25 years, even though I'm still at the university in the VA, with my time cut back, my true love is educating and motivating people with diabetes and their loved ones to take a more active role in their condition. So it's all about knowledge. And so I gave up on educating doctors for a long time, and I focused only on people living with diabetes. And now I realize you got to do both. So now it's professional and patient education in a parallel approach so that there's better communication between them. And that's what I've been drilling down on with the patient education part at this part of my career, because I'm not doing big research studies anymore. You see all this gray hair?
Thank you so much. Both of you have such wide experience with diabetes education, and also thank you, Donna, for sharing about your brother. I didn't know that either, and I think the diabetes community really thanks you for the work that you've done as well. I wanted to ask, while this may seem basic to you two, many people, even those who live with diabetes, could benefit from some clarity. What are the distinguishing features between type 1, type 2, and gestational diabetes as the three most prevalent or main types of diabetes?
Well, we can take turns going first, Donna. Well, gestational usually only occurs in women. You're supposed to laugh, Amanda. Okay.
I'm processing.
Jeez, you guys are slow. Well, let me just say first to everybody that's watching and listening, there are many types of diabetes. And so, even for younger doctors, it's not just type 1, type 2, gestational. So it's important to know that, because a lot of times in clinic, we'll get someone, they'll say, they don't have the features of type 1, they don't have the features of type 2, they might have some other type. So, but you're right, those are three big buckets. Type 1 is a autoimmune condition that leads to the destruction of the insulin producing beta cells of the pancreas. Traditionally, there's no insulin resistance, there's no central obesity, there's no other clinical features that we see in type 2. Typically, you get it when you're younger, but you can get type 1 diabetes at any age. And type 2 is a very genetic condition. I think 80 to 85% of people that have type 2 runs in their family. That's untrue for type 1s, where it's only 20%. And people with type 2 have a genetic predisposition to develop a whole host of metabolic syndrome, central adiposity, high cholesterol, high blood pressure, obviously high glucose, propensity to develop little blood clots, and the higher incidence of heart attacks and strokes. And the therapies traditionally have been quite different, but we can talk about it later. Some the therapies now are overlapping. And so those are the two big buckets. And then, of course, gestational diabetes is when you get diabetes when you're pregnant. And there's also diabetes of pregnancy. These are women who already have diabetes and then they get pregnant. So gestational specifically refers to women who do not have diabetes, but develop it during pregnancy. And it's mostly a type 2 picture most of the time. I don't know, Donna, this is not one of those questions where you start from scratch, but anything to add, and then you get to go first next time.
Okay, well, I was going to add because that, we've both been working in diabetes for many years, and it used to be that we call type 1 and type 2 based on either age or whether they used insulin or not. And I think that's something important for people, especially the younger generation, to realize that terminology we don't use anymore. Juvenile onset is used to be the type 1, and you only get it when you're a kid. It has to start then. So we don't use juvenile onset, and we don't use adult onset because we've learned that it's all over the lifespan of when these conditions can start. So that's old, as well as insulin dependent or non-insulin dependent. In the diagnosis, they can describe how someone is treating their diabetes, but we stay away from that terminology talking about the types of diabetes. The way Steve described it is what we use now, type 1 and type 2. We also used to use Roman numerals. We don't do that anymore.
Yeah, that's right. That's right. But you can also get, as I mentioned, you can get type 1 when you're 70 years old, and you can get type 2 when you're 8 years old. So just to add to what Donna was saying.
And the other thing with gestational is it's important for everyone to know that many times it goes away. Most times it will. The blood sugar, I say go away. The blood sugars go back to normal after the baby's delivered and the mom recovers. But there's a recurrence that happens, a frequency that happens, especially in some ethnic groups that will come back with pregnancies. And it can develop and increases your risk of getting type 2 diabetes later in life, so sometimes sooner than later. So it's really important that anyone who has gestational follows up with checkups right after they deliver and then annually thereafter to make sure that it doesn't come back, because we see that quite a bit. And it's not type 2, and it gets treated like type 2. Use a type 2 diet, use a type 2 glucose goals, and it's its own unique set of criteria and treatment. So it's really important.
One of the most determining factors if a woman with gestational diabetes, if diabetes goes away after delivery, the chances of it coming back is based on their weight later on. So it's really important to add on to what Donna said. Besides regular checkups, do everything you can to get as close to your ideal body weight as possible. And if it runs in your family because of genetic and ethnic backgrounds that have a high rate of diabetes, then your chances are even higher. And it's important to pay even more attention to that.
Thank you for clearing those up. Hopefully people have a more clear understanding of the three now. I wanted to ask Donna and Steve, you're both teachers in different contexts, as we heard earlier, singing your praises. Donna, you have worked as a registered nurse, dietitian, diabetes educator, and Steve, you're an endocrinologist and a professor of medicine. When educating people with diabetes about their conditions, which aspects of diabetes, both in terms of its science and its management, do you emphasize the most? Stephen, you also have the added context of educating non-people with diabetes, like physicians, about diabetes. Please share with us both of your experience there, if any.
Donna, you please go first this time.
Well, I always start off by saying one size doesn't fit all, and to everyone's diabetes is different from everyone else's diabetes, and it can be different from day to day. So it's really important to get individualized care with a healthcare team that specializes in diabetes, and that's where the education starts to. Dr. Google can kill you. You Google, and we see that all the time when we have kids and adults diagnosed in the hospital, they pull out the iPads and they just start moving like crazy. It's a good place to start, but it will not give you the individualized education that's really based on the type of diabetes, your lifestyle, and what you have access to. So one size doesn't fit all, and it's lifelong learning. So what you learn when you get diagnosed versus as you progress with your diabetes, it is something that you want to keep up with. One of the things I start with too is there's a lot of misconception about we cause our diabetes. If you listen to the media, if you listen to family and friends, you ate too much sugar, you caused, whether, especially with type 2, there's a lot of blame and shame with that. So I try to normalize that. No one wants this. No one caused it themselves. It's either, it's all related to physiology and heredity, and if we caused it, then we would see a much larger percentage of people with diabetes that have obesity or that have poor lifestyle choices. So that's the baseline of where I start, and then definitely then go into the cultural aspects of preferences of eating and exercise and stress, and making sure that it all fits together. So to live your life and make diabetes fit into it, not make everything about diabetes in your life. Does that make sense?
Thanks for that, Donna. It was really, really important stuff that you mentioned. Well, like what Donna said, you got to know who your audience is. So, for example, part of my week is working with medical students, residents, endocrinology fellows, and in that situation, we see patients together, and we do talk a lot about the science and the pathophysiology of the different types of diabetes, because that relates to the different types of therapy that the patient may be on and what we may add. But I think following up on that is I want to educate these healthcare professionals, the doctors of the future, the diabetes specialists of the future, that living with diabetes is tough. To add on to what Donna was saying, and that they can't be blaming a patient who comes in who, let's say, was not pricking their finger as many times as they were told. They're not non-compliant, which has a negative connotation to it. So try to educate them. I politely tell them the correct phrase is, patient has had a hard time keeping up with our suggestions, and that life gets in the way, and who likes to prick their effing finger 6 times a day, and so living with diabetes is tough, and I want to instill that up to the younger doctors. Now, dealing with people with diabetes at our conferences, now mostly virtual, Donna has spoke at them, is that I agree with Donna. We want to make sure that we take off the shame and blame, explain to them why most type 2s have weight problems, the central abdominal weight problems. They didn't eat themselves into getting diabetes. It was genetically determined at birth. And most people start to develop these symptoms or these physical signs, 30, 40, 50, depending how strong the genetic tendency is. And I think it's important to educate people on the different medications and devices in a way that doesn't scare them, that makes them understand how they work, and very importantly, if these different drugs and devices would be helpful to them. And then we encourage them to speak to their healthcare professional and ask for these advances, with the caveat that it's an appropriate ask. So we want people to know that GLP-1s, they're not out there just to lose 10 pounds before your daughter's wedding. They're there for weight, cardiovascular, kidneys, heart, fatty liver, and I get too technical on the show. So it's one of those things where education is power. And so you can educate people on the science of the condition, the medications, but then there's the whole other area that Donna really is much more experienced than me, which is on the touchy-feely part of it. And that's key. So Bill Polonsky, clinical psychologist, very famous diabetes clinical psychologist, one of them, he speaks a lot at our conferences, and it's such an integral part of it, because if you don't have the emotional buy-in by the patient, if they're not motivated, you're not going to get them to where they should be. Sorry, I went on forever on
Oh,
that
that's
one.
good.
No, this is an important question. And you guys have been doing such great work as diabetes educators to help the entire diabetes community. Just to perhaps turn to the advocacy legislative side of things for a moment. We wanted to ask, if you were talking to a legislator about diabetes, what is a very simple way that you would educate them about differences or similarities between the types? And a lot of our advocates would also like to know this kind of question, because we're talking to our legislators and we don't know exactly what to emphasize, what they might not know, what the basic public does know. So what's a simple way that you would talk to a legislator about this?
Donna, you have experience. You want to go first?
Well, the similarities are that it is a condition that affects their constituents and the people they represent, wherever you are. And it is 24/7. We live with diabetes. It doesn't go away, and it's bipartisan. It doesn't affect one group of people more than other. Having access. So the similarities is a challenge, and it's expensive. And we need legislative help to make access more affordable and more equitable. So the similarities are yes, everyone needs access to medications, the devices, the CGMs, the pumps, the glucose meters, and it needs to be in broad stroke. There's not one size fits all when you're looking at medications or meters or pumps. For differences, going back to what we said. So we have kids with diabetes as young as 6 weeks and 6 months, they get diabetes, and we've got octogenarians, 89-year-olds with diabetes. The type 1 and the type 2 can certainly influence what kind of support that they need. But it is lifelong, and it needs to be type 1, type 2, and gestational need to have the access that we talked about.
Yeah, well, I can add on a little bit to what Donna said. I haven't spoken to too many legislators, to be honest. I avoid politics like the plague. And I've been on meetings with Governor Newsom a few times about getting CGM approved on Medicare, Medicaid. But what I try to do first is I ask them, do you know anybody with diabetes? And it's rare to find someone that doesn't know someone with diabetes. And God forbid they had an experience like Donna with one of their relatives had a negative outcome, renal failure, blindness, amputations. And then there's a lot of famous people with diabetes. And I think, to tag on what Donna said, diabetes affects every socioeconomic, crosses all boundaries. And people need these medications. They're not cosmetic medications. Therefore, they're so important. And sometimes they'll listen to the economics of it, that the cost of taking care of someone on dialysis, a couple $100,000 a year, and what that could buy on more preventative measures. But I think, in addition to access to the best drugs and devices, you have to have access to healthcare professionals who know how to use them. And these days, Amanda, it's really tough to get in the clinic. I don't know what happened after COVID. All of a sudden, access is one of our biggest problems. I'm at UCSD, and if you called up today to get an appointment with an endocrinologist, it's 3 to 4 months. And even if you had a serious problems with your glucose control, and if you take someone that's indigent or without not access to a major university, and then you have to find a healthcare professional who knows how to use insulin, that's big, because we know, Donna and I have seen lots of disasters out there, and it's no wonder that most of Americans have an A1C that's way too high, in the range where you would develop complications. So, and don't forget, type 2s need cardiovascular risk reduction. Well, we all do, but blood pressure, cholesterol. So it's a multifaceted condition that needs educated healthcare professionals and then access to the best medication. So we have a long way to go in this country, Amanda.
Yeah, we know that's true. As DPAC, that's our main thing, educating legislators and educating advocates on how to talk to legislators. So thank you so much for telling us your perspective on what you would say. We are coming close on time, so we might run over a little bit. And if you have to drop off at 10:30, this is toward the audience, feel free to just drop off. But our next question, I'll consolidate the next two. What are some misconceptions about type 1, type 2, and gestational diabetes?
Well, I'll just say a quick comment because we're short on time. I think Donna would agree that we've already mentioned it, misconception that people with type 2 diabetes are fat, they're lazy, they're slobs, and that's why they got type 2. And, it's a serious condition that comes later in life, and people have a lot of other issues. The misconceptions with type 1, that we're all well-built athletes like myself, but that's not true either. The most common cause of death I'm joking, but you guys don't, Donna smirked a little bit.
Yes.
I'd say the biggest misconception in type 1 is, what's the main reason of type 1's passing away? It's cardiovascular disease. So we used to think that's all type 2. So everyone on this planet, diabetic or not, but especially people with type 1 and type 2 diabetes, have to really focus on cardiovascular risk reduction. The basics: heart, blood pressure, hypertension, getting on a blood thinner, aspirin if you're at over 50, stuff like that.
And I think with legislators, it's and just in general, diabetes care is preventative care. If we can get people the doctoring, the education, the resources that they need, we can prevent these complications that legislators are looking at. The cost of hospitalizations, ER visits, dialysis, amputations, all those terrible things. And they look at it from a dollar perspective. So that's a really important point to bring across, is you can prevent these expensive outcomes that cost state governments and the federal government a lot of money, and by providing the basics to prevent the cardiovascular, the renal, and acute and chronic conditions that we have. And then I also want to say, Amanda, I've done a lot on Capitol Hill and at the state level, and there's nothing more powerful than the advocates that are here on this call. When you sit down and you tell your story, your challenge, what it means to you, and as Steve said and asked, do they know anyone with diabetes? That many times just opens the floodgates of what to talk about, and brings that personal touch to. You talk about your type of diabetes. You talk about what it what it takes you every day and every month and every year, and how it's affected your life and your job and your family. That's what they walk away with.
Yeah, thank you so much. Yeah, there are tons of facts and numbers thrown at them all day, but it's really the personal stories that do stick with them. What are some commonalities between the 3 types of diabetes we mentioned, and are there other types beyond these 3? I also wanted to point out, in the Q&A, there are some people who are talking about different types of diabetes other than those 3 that they have experienced as well. Feel free to address those, and as you talked about the 3 types.
Well, I can say a few things there. We talked about that in the very beginning. There's many different types of diabetes. There's a condition called monogenic diabetes, mature onset diabetes of the young. It's a small group of people. It's a genetic condition, and there's 13 different types. So it can confuse the healthcare professionals. Then we have sometimes people will say LADA, LADA, latent autoimmune diabetes in adults. It's basically type 1 diabetes later in life, and it presents a little less traumatic. People don't usually go into ketoacidosis. And there's diabetes of people who get cystic fibrosis. There's other conditions in endocrinology where there's too many hormone levels, other types of hormone levels that work against insulin, like, ready for this, a glucagonoma or pheochromocytoma. These are conditions where you secrete hormones that work against insulin. People have, you've heard of Cushing's disease, or the person's, their own body produces too much steroids. And most people know that steroids work against insulin. So I think there's a lot of different types. It's important for healthcare professionals to know those types, because when someone doesn't respond normally or doesn't present normally, they should be thinking of these other causes, which has therapeutic implications and genetic implications.
Working in the hospital, we see a lot of the steroid-induced diabetes as a diagnosis or a description. So there are medications that, but the similarity is the glucose levels are above normal for whatever the reason. And we know the higher they go, the more complications you get, either sudden acute complications or more long-term complications. So that's the similarity. Is we've got to diagnose correctly and get the blood sugars as close to normal as possible.
Yeah,
Normal blood sugars are the cause of nothing, right? I'm quoting Bill Zelensky, right?
Used to always say that Donna is exactly right. The causes may be different: insulin resistance, lack of insulin, all the gestational hormones that are anti-insulin hormones, but we're all blood brothers, because the commonality is elevated blood sugar, and elevated blood sugar over time, and it can cause acute problems, but over the long term can cause the chronic complications. So yeah, we're all related glucose wise, for sure.
Yeah. Our final question, I know we're over time, but in your work educating patients or students or physicians about the understanding of diabetes, is there misinformation that you find yourself often having to correct? And what is the most important piece of information that you try to relay?
I'll put on my nutritionist hat. I'm a registered dietitian, and the most common is the vilifying carbohydrates and white bread and white this. And I have doctors and people, pregnant ladies, being told they can't eat anything white, they can't eat anything carbohydrate, they have to stay. So that's a battle in the trenches that we fight. And I think our listeners here have heard it too. Even with type 1, there's a huge misconception about, well, you could just cure this if you just didn't eat that. So that comes to mind immediately for me. How about you, Steve?
Yeah, there's so many dietary misperceptions, but I would say what comes to mind is, we talked a little bit about this when we defined diabetes, is that when you're a type 2 and you need insulin, which is very common, 40% of type 2s need, whether it's 1 shot a day of basal or whatever, a lot of doctors say, oh, they're a type 1 now, or residents. And, when you're a type 2, you're a type 2. So the best way to characterize that is an insulin requiring type 2, not insulin dependent, because true insulin dependence is type 1. And so I'd say that's one of the biggest misperceptions. And I think the other thing I touched on, which is pervasive, is that most people with diabetes do not have an A1C goal. Only about 25 to 30% of type 1s at the best, because type 1 is hard and most people cannot get their A1C less than 7. More and more these days with our technology, and not even 50% of people with type 2. So the perception that a big part of this is non-compliance. I touched on that earlier. And I just wish that one thing we push is try to get caregivers to empathize what it's like to live with diabetes. And that's something that's really missing, that and they get a bad stigma. You get a doctor who writes in the chart, non-compliant 55-year-old type 2. Then the next person that comes in looks at the note, they're already starting off with a preconceived notion. This guy's a slime ball, he's non-compliant, he doesn't care about himself. Why should I spend any quality time with him? That happens a lot, believe it or not. Ugly secrets of medicine.
Yeah, that's terrible, and it's also very important for us to know, because we attempt to counter stigma, not just within the diabetes community, but in situations like this in the medical community for all that we can do. And yes, thank you so much, Donna, for highlighting the dietary portion of it. I know we all know as people with diabetes, like the keto diet has us in a chokehold trying to explain that this, that's not what we need to do. And
Amanda,
in general,
one quick thing. If you think of all the famous people with diabetes, the ones that come out of the closet, they're all type 1s.
yeah,
No one gets up there and says, I have type 2. But look at all the famous actors and athletes that have made a career out of having type 1. Phil Sutherland with Team Type 1, there's a zillion of them. And because there is a stigma to type 2. And I think
yeah.
that's a tough problem to address and change. Sorry.
Yeah, no, thank you for saying that. It's really important because I think a lot of people have a misconception about type 2 being just totally self-inflicted, which is what we were talking about earlier on this call. And they ignore that there are so many genetic and socioeconomic factors that come into play for type 2.
And
So
a
thank
lot
you.
of our politicians probably have type 2.
Yeah.
So that might be something that your advocates might have in the back of their mind to talk about that issue and how we have to really educate people that it's not anyone's fault. And they're going to go, hey, I got type 2.
Yeah, especially within, I mean, I'm sure as someone with type 1, there's within the diabetes community, a lot of type 1s want to say these things to distance themselves from type 2s, be like, oh, I have the, not the bad one, the good one. And, like so much, which it doesn't help us, it just hurts us all as a community, which people don't realize. So yeah, and then also you brought up earlier about the idea that type 2 turns into type 1. I know as a type 1 myself, I've heard a lot of people say, oh, I had type 2 that turned into type 1, or so-and-so had turned into type 1. And I've always been so confused hearing that, like, what do you mean? And that's just goes to show how much misinformation there is within medical professionals and within the diabetes community. So thank you so much. I know we had some questions in the Q&A that we couldn't get to, but please feel free to email us and we will address all of your questions. We did try to address the different types of diabetes. But thank you everyone for joining us today. Feel free to email us or hit us up on social media with any questions. And thank you, Dr. Edelman and Dr. Bryan, for being with us today.
Okay, thank you very much.
Have a great day, everyone.
Okay,
Thank you, everyone.
Donna, good seeing you.
Good to see you too. Everyone.